Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Shireen Qasim from the Pediatric Department. Today, the topic we are going to discuss is congenital hypothyroidism, which is the most common preventable causes of mental retardation in children. First, we'll discuss about the thyroid gland. Thyroid gland is basically an endocrine gland which is situated at the root of the neck on either side of the trachea. It has two lobes which are connected in the middle by the isthmus. Thyroid gland basically involved in the synthesis of three hormones, that is tetraiodothyronine, which is called T4 thyroxine, triiodothyronine T3, and calcitonin. The main function of the thyroid gland is to increase the basal metabolic rate. It is involved in the growth and neurodevelopment in children, also stimulates the synthesis of the protein, carbohydrate, lipid, and vitamin metabolism. For the synthesis of T4 and T3, the body needs iodine, and iodine is only involved in the synthesis of these hormones. Recommended dietary allowance of iodine is 30 microgram per kg per 24 hour in infant, which increases to 90 to 120 microgram per 24 hour in children, and in adult it's 150 microgram per 24 hours. Now, how the thyroid hormones are secreted? They are basically controlled by the hypothalamus, which releases the thyroid releasing hormone, which stimulates the anterior pituitary to release the thyroid stimulating hormone, that is called TSH, and that TSH then acts on the thyroid follicle and release the T3 and T4. The most T3 in circulation is produced by the peripheral conversion of T4 by the deiodination of T4 in the liver, kidney, and the peripheral tissues. As we have discussed, that the primary function of thyroid gland is to secrete T3 and T4, which are under the control of the thyroid releasing hormone and thyroid stimulating hormone by the hypothalamus and the anterior pituitary. The serum T4 concentration is basically which modulates the secretion of both thyroid releasing hormone and thyroid stimulating hormone by the loop called classic negative feedback loop. When the T4 concentration is low in the body, the thyroid releasing hormone is stimulated, which acts on again the TSH and causes the release of the T4. When T4 obviously is high, then the TRH and TSH secretion decreases the secretion of the T4. So it is basically a feedback loop mechanism. This slides give you an idea about the thyroid hormone biosynthesis. We have three portions. One, the extreme left is the lighter pink area, which is the thyroglobulin part. The blue area is the thyroid follicular cell, and the deeper pink part, which is extreme right, is the plasma or the blood. Now, from the blood, iodide is transported inside the thyroid follicular cell through the sodium iodide co-transport system. That iodide then it transported back into the thyroglobulin, where it is oxidized to iodine, and then iodination takes place. In the thyroglobulin, basically the main formation of T3 and T4 takes place, which we will explain in the next slide. And after this iodination and conjugation, formation of monoiodotyrosine and diiodotyrosine, they are then transported back into the thyroid follicle by endocytosis, and from there they are then transported back to the plasma as thyroxine and triiodothyronine. This is basically what actually occurs in the thyroglobulin molecule when iodide is transported into the follicular cell by the co-transport system. It is oxidized, that is by the peroxidase, and it is oxidation takes place to form iodine, and that iodine is then transported into the thyroglobulin molecule. Within the thyroglobulin molecule, iodination takes place, that is iodine is combined with the tyrosine and they forms the two molecule. One is the monoiodotyrosine and the other is the diiodotyrosine. Two diiodo molecules, when they combine, they will form the tetraiodothyronine, that is the T4, and one molecule of monoiodotyrosine and one molecule of diiodotyrosine, they both combine to form the triiodothyronine, that is the T3. This T3 and T4, which is formed in the thyroglobulin, then they are again transported, as we have seen in the previous slide, back to the follicular cell, and then from the follicular cell they are transported into the plasma. This is the steps which takes place in the thyroid hormone synthesis. Just a short a list so that you can go through it. Hypothyroidism usually results from either decreased production of thyroid hormone or a defect in the thyroid hormone receptor activity. Decreased production of thyroid hormone has significant impact on growth and development. It can manifest at birth, that is known as congenital hypothyroidism, or can be acquired later in life due to other causes like autoimmune thyroiditis and other reasons. Congenital hypothyroidism, that means deficiency of thyroid hormones since birth. It has a frequency of 1 case per 1500 to 3000 live births in United States. Thyroid dysgenesis, being the commonest cause, affects 1 in per 4000 newborns worldwide. Hypothalamic or pituitary insufficiency, which results in secondary or tertiary hypothyroidism, affects 1 per 60,000 to 1,40,000 newborns worldwide. Hypothyroidism could be caused by defect in the hypothalamus, pituitary, thyroid gland, or in the peripheral sensitivity to thyroxine. Thyroid dysgenesis is the most common cause of congenital hypothyroidism in non-endemic areas. The disorder encompasses a spectrum ranging from complete agenesis to partial agenesis, dysplasia, or ectopy of the thyroid. Most of these disorders are sporadic and no genetic association has been observed. Increased incidence of thyroid dysgenesis is noted in children with Down syndrome. Biosynthetic defects include disorders affecting the iodine transport, peroxidation, thyroglobulin synthesis, and deiodination. Transient congenital hypothyroidism may occur following a transplacental passage of thyroid stimulating receptor blocking antibodies, iodine exposure, or treatment with drugs like amiodarone. Some cases has been reported to be caused by autosomal recessive defects in the organification of iodine and defects in other enzymatic steps in T4 synthesis and release. As we have discussed in the previous slide, 75% of the infants with congenital hypothyroidism, they have defects in the thyroid gland development, dysgenesis, agenesis, aplasia, hypoplasia to functional ectopic thyroid tissue. Familial thyroid dyshomogenesis are autosomal recessive disorders. 10% have hereditary defects in thyroid hormone synthesis or uptake. 5% have secondary, that is pituitary, or tertiary, that is hypothalamic cause of hypothyroidism. 10% can have transient hypothyroidism, that is because of the maternal exposure to radioiodine. Mothers who are hyperthyroid and on treatment like propylthiouracil or methimazole, or mothers with maternal thyroid stimulating hormone binding inhibitory antibodies. The central, that is the secondary hypothyroidism, it refers to defect in the production of thyroid stimulating hormone, that is TSH, due either to the hypothalamic or pituitary dysfunction. If an infant has central hypothyroidism, Then the clinical manifestations are often related to associated deficiencies of the other pituitary hormones, like we have defect in the growth hormone and adrenocorticotropic hormone ACTH. We can have babies with hypoglycemia soon after birth, or deficiency of growth hormone and gonadotropins, that is FSH and LH, can lead to micropenis, that is a small size penis. Undescended testes, that is again due to the deficiency of gonadotropin, and vasopressin deficiency can lead to diabetes insipidus. This is a chart which shows the different causes of hypothyroidism, that is primary hypothyroid, central and transient hypothyroidism, along with different levels of T4, free T4, T4 and TSH. Condition in which it is either increase or decrease. It's just it is given for to you for a reference so that you can go through it. You don't have to learn it. Now the history depends on the age at presentation. Features of congenital hypothyroidism are non-specific and are difficult to identify in the neonatal period. These features will become prominent as the child age increases. Clinical manifestations usually includes prolonged gestational period. Babies are born with good weight or elevated birth weight. There is history of delayed passage of stool after birth, or the child can have constipation. Prolonged indirect jaundice, hoarse cry, facial puffiness, umbilical hernia, hypotonia, mottling of the skin, lethargy, that is decreased activity level, noisy respiration, that is because they have large tongue and that interferes with the normal breathing. Prolonged jaundice, constipation and unexplained hypothermia may also be indicators of hypothyroidism sometimes after birth. Open posterior fontanelle is also an important indicator of congenital hypothyroidism. Detection of congenital hypothyroidism based on signs and symptoms alone may be delayed until 6 to 12 weeks or older. That's why screening at birth is very important and necessary for all the babies. On physical examination of a child with congenital hypothyroidism, when we check the pulses, they usually have bradycardia. They are good weight babies, so their weight is higher than a normal baby. They have sluggish or lethargic behavior. The normal neonatal reflexes are not very elicitable in these babies. They rarely cry, or when they cry, they have a hoarse cry. Hoarse cry is secondary to myxedema of the vocal cord. Myxedema is basically the edema of the vocal cords. They have large fontanelle. There is puffiness or myxedema of the eyelid, hands and scrotum. They have large protruding tongue, secondary to accumulation of myxedema in the tongue, and that large protruding tongue basically produces the noisy breathing. Some babies can have a swelling, that is called goiter. Umbilical hernia, delayed relaxation of deep tendon reflexes. They have hypothermia and they have dry scaly skin. The cardiac shadow on the X-ray is usually enlarged, and because of they can be pericardial effusion. Prolonged conduction time and low voltage on the ECG. In this picture, you can easily appreciate the poor muscle tone, the lethargic position of the child. Jaundice is not easily visible in this picture. Large or long protruding tongue. Umbilical hernia can easily be appreciated. If you feel the anterior fontanelle, that would be quite large and wide anterior fontanelle, and if a temperature is taken, these babies usually have low body temperature. Similarly, in this child, you can again appreciate the child is ecteric as compared to a normal child, jaundiced. large protruding tongue, and they would be and there is umbilical hernia. These children, as we discussed before, they have dry skin, they have slow reflexes, and a hoarse voice. If diagnosed at a later stage, if usually the newborn neonatal screening is important in these children, because in that cases we can easily identify the cases at an early age, and we can start the treatment early. If diagnosed at a later age, then the child will have slow linear growth, they have low IQ, the child will be ataxic, the child will have hypotonia or will have a hypertonia, that is spasticity. Usually the gross motor and fine coordination is not there. Speech disorder or delayed speech. Attention deficit is there. 10% babies can have sensorineural deafness and strabismus. Cretinism is another term which is also used for congenital hypothyroidism, that is purely because of lack of thyroxine from birth. It could be from lack of thyroid gland or lack of iodine in the mother. It is a severe and irreparable mental defect. The babies have stunted growth, and they have reduced growth and function of many organs. You can appreciate the picture. The child have puffiness of face, depressed nasal bridge, large tongue, and the face is swollen. These are other two pictures of hypothyroid babies who have gone through the neonatal period. They are in the infancy or in the childhood age. They were not diagnosed early, and therefore the treatment was delayed. Delay in treatment beyond 6 weeks of life is associated with substantial risk of delayed cognitive development. This is another pictures of hypothyroid babies. Workup and evaluation is the cornerstone in the treatment of congenital hypothyroidism. Serum thyroid stimulating hormone concentration remains the most sensitive screening test for the hypothyroidism and for establishing the diagnosis of primary hypothyroidism. It is also used as a guide when we are treating the babies with thyroxine. Doses can easily be decreased or increased according to the TSH levels. Total T4 assays measures both the free state and bound to the thyroid binding globulin that assess the response to treatment. We do both the tests, the total T4 and the free T4. Usually the free T4 and TSH are the most important tests that are usually done to diagnose and then to follow up the babies on thyroxine. Other investigations include thyroid ultrasonography that will give us the thyroid shape, the size, the location, or if the thyroid gland is in ectopic in position, like in lingual, sublingual, subhyoid areas, or it can differentiate between a no thyroid tissue or a thyroid hyperplasia. Similarly, radioisotope based thyroid scanning, it is done if the ultrasound study does not detect the ectopic thyroid tissue, then a thyroid radionucleotide uptake and scan can help identify the cases of thyroid dysgenesis. Radiological examination is very important, and therefore we do the X-ray of the hand, which give us we see in the next slide the different radiological views. Skeletal maturation is delayed, therefore the bone age, like the height age, is less than the chronological age. Bone age is the age which we identify visualizing the X-ray, and chronological age is the actual age of the child according to his or her date of birth. So the bone age is less than the chronological age. X-ray of the knee, that will provide useful information regarding the degree of severity of intrauterine hypothyroidism by the presence or absence of femoral and tibial epiphysis. Here in this picture you can easily appreciate, the first picture is the epiphyseal dysgenesis. You can appreciate both the epiphysis, which where there is improper growth of the epiphysis. Similarly, because of epiphyseal dysgenesis, there is shortening of long bones. In the second picture, you can appreciate both the lower ends of the bones. They are friable, and they are even not properly formed. The line of demarcation is not there. When we do the X-ray skull, we have large fontanelles. You can appreciate in the upper part, the anterior fontanelle, and the sutures are very wide, which is not easily appreciable in this X-ray. Other tests that we do in congenital hypothyroidism is the thyroid autoantibodies. That is the measurement of thyroid antibodies for infant born, especially to mothers with known autoimmune thyroid diseases. Serum thyroglobulin, that basically distinguish among the causes of congenital hypothyroidism. For infants with no thyroid gland seen by imaging, a low serum thyroglobulin level is consistent with thyroid aplasia. While infant with large gland on imaging, a low serum thyroglobulin level point to thyroglobulin gene defect. So you can easily differentiate between the causes of congenital hypothyroidism. Urinary iodine excretion, if there is a history of iodine exposure, iodine-induced hypothyroidism or iodine deficiency, the urine iodine excretion can confirm an excess or a deficient state. Now we come to treatment. If a child, infant or a child with low T4 and an elevated TSH, treatment should be started on L-thyroxine as soon as the diagnosis is made. Again, as we said before, delay in treatment beyond 6 weeks of life is associated with delayed cognitive development. Newborns with elevated TSH should be treated empirically with thyroid hormone replacement until they are age 2 years to eliminate any possibility of cognitive deficit. Therapeutic goals are normalization of thyroid function test and elimination of all signs and symptoms of hypothyroidism. The initial dose of L-thyroxine is 10 to 15 microgram per kg per day. Infant with severe hypothyroidism, that is very low T4 and very high TSH, and absence of distal femoral and proximal tibial epiphysis on radiograph of the knee, should be started with a higher dose of thyroid, that is 15 microgram per kg per day. Initial evaluation and follow-up can be conducted on an outpatient basis. The preferred preparation is sodium levothyroxine. It has a uniform potency and a reliable absorption and a good bioavailability. How it is given? It is given as a daily dose. It is given in the morning, and it should be crushed and placed directly on the tongue in the morning. In newborn babies, sometimes the taste is not is different, so it can be mixed with the breast milk. Iron and calcium preparation, they interfere with its absorption. If a dose is missed, then double dose should be given on the next day. You can appreciate in this picture that the face that is before the treatment, a full puffy face, which is the myxedema, puffed up, dull looking face, protruding tongue, and after treatment you can see an alert looking baby with the swelling has reduced and tongue is also coming to its normal size. Now, how do we monitor these babies? The T4 and TSH should be monitored according to the following schedule. Usually 0 to 6 months, till 6 months of age, every monthly evaluation should be done. After 6 months, that is 6 months to 2 years, every 2 to 3 months this T4 and TSH can be checked. Beyond 2 years, every 6 month evaluation should be done. 6 to 8 weeks after any dose change, when we change the dose after seeing the T4 and the TSH, if there is a change in the dose, then it should be done at 6 to 8 weeks. It takes less than a week for a T4 to raise and 4 to 5 weeks for a TSH to normalize. Over treatment should be avoided because it can lead to craniosynostosis, that is early fusion of the sutures, and temperament problem. Newborn screening is an important part of evaluation of every newborn. Avoidance of administration of radioiodine to women who are pregnant is the important way to prevent this disease. Neonatal screening is an important part of diagnosing babies with congenital hypothyroidism. Difficulty in early identification of congenital hypothyroidism and disastrous consequence of delayed diagnosis have led to the neonatal screening for hypothyroidism. These screening programs use dried blood sample collected from the heel of the babies at the postnatal age of 2 to 4 days. We measure the T4 and the TSH levels. False positive cases are there, but especially in the preterm infants. Thyroid function should be repeated if TSH levels are above 20 millimoles per liter. Confirmation of hypothyroidism should be followed by etiological investigation like thyroid scan and thyroid ultrasound. Thyroid hormone replacement should be started as soon as these investigation has been performed. Neonatal screening has significantly improved the intellectual outcome in congenital hypothyroidism with IQ scores similar to the general population. Universal screening, most cases are sporadic in iodine sufficient areas, and intellectual impairment can be prevented if treatment is initiated early. In the absence of universal screening, newborns with following indications must be screened: having clinical features of congenital hypothyroidism or family history, history of any thyroid disease or anti-thyroid medication intake in mothers, presence of other conditions like Down syndrome, trisomy 18, neural tube defects, congenital heart disease, metabolic disorders, familial autoimmune disorders are associated with higher prevalence of congenital hypothyroidism. This is an algorithm to approach a newborn with a positive screening test for congenital hypothyroidism, as we have already discussed. We positive screening test for on a filter paper sample taken from the heel of the baby. Serum T4 and free T4 and TSH were done. If it is normal, fine. If it's abnormal, we do a thyroid scan that will check the ectopic thyroid. Ectopic thyroid, then we go for ectopic thyroid evaluation. And if the thyroid scan absent uptake or a normal, we have to differentiate between a normal, absent uptake, and an ectopic to diagnose dysgenesis, ectopic thyroid and agenesis. Now, when a child is on treatment with thyroxine, there are other consequences of overtreatment. Either the dose is very high, or the child has lost to follow up. Although the symptoms are, because the symptoms are improving and the child's behavior is improving, so usually patients don't come to follow up, and therefore as the child TSH and T4 levels start coming to normal level, the doses of the thyroxine is reduced, and if it is not reduced, then it can lead to overtreatment, and overtreatment will lead to adverse behavioral changes. The child will be irritable, will have temperament problems, lower school performance, lower IQ, and can affect the bone mineral density. The prognosis for patients with congenital hypothyroidism is appropriately treated within 6 weeks of birth is excellent. Worldwide screening programs for congenital hypothyroidism have a significant impact on reducing the intellectual deficit in hypothyroid infant diagnosed and treated early. Overtreatment with thyroid hormone does not enhance the catch-up growth and may compromise the final adult height by advancing the osseous maturation. Untreated congenital hypothyroidism in early infancy will result in profound growth failure, disrupted development of the CNS, leading to development of cognitive delay, that is cretinism. Untreated hypothyroidism in older children that lead to growth failure, they would be stunted, slowed metabolism and impaired memory. So the take home message is compulsory screening in the neonatal period. Repeat the test if we have any doubt. All babies with low T4 and high TSH, they are congenital hypothyroid until proven otherwise. Consultation with the pediatric endocrinologist is important. Screening should not delay treatment. Early treatment and early recovery is the cornerstone of treating and managing congenital hypothyroidism. Thank you so much. If you have any query, any question, you can email me at my email address, that is drshbham@yahoo.com. Thank you so much.